Thank you very much for the opportunity to tell you something about our already 25 years experience with IORT in pelvic diseases, and most of it is primary advanced rectal cancer, but nowadays it's mostly recurrent cases. And well, the title which was given to me would mean that my presentation would be over in 2 minutes or something like that, because as Alex already told you, there is very little concrete evidence, and it's the evidence we like to see, you know, in randomized controlled studies. We have tried to do these, but the problem is if you enter easy patients that do not require IORT, as Alex told you, then you probably will have very good results. So, but if you enter these cases, then you have these are very rare cases. So in our 25 years experience, I treated now some 700 cases for locally recurrent rectal cancer, but it took me almost 10 years to get more than 50 cases. You know, in the first 10 years we did 50 cases of locally recurrent rectal cancer, and now we do 60 cases a year, and it's still climbing, the number. In the Netherlands we have 5 centers dealing with locally recurrent rectal cancer. In a way it's centralized, and it's, I think that's a very important prerequisite to be able to move on and to learn from your own patients. When we started our program, we just didn't know what to do, and we just tried things, and there were very few centers doing this in the world. But now I think we are quite at a different stage. So where are we at this moment? This is from the pelvics group. It's a group of centers dealing with excentrative surgery. Most of you probably will heard of it. It's led by Des Winter. And he asked, what are your results actually at this moment? What can we say about results of excentrative surgery? And this is what we have. And I think we cannot be satisfied with these numbers. Even after R0 resection, only 30% long survivors. And of course, this issue is really the issue we're talking about in this kind of surgery. An R0 resection is really necessary. R1 resections are still a problem, and maybe IORT can help in this, but it is still a huge problem, and R2 resections are really still dismal. What was not understandable for me is that neoadjuvant treatment does add just such a little bit to the outcome of this treatment, which you can see in this slide. It's the same publication from the pelvics group. So what is actually about? This is a paper from the Royal Marsden group, and as you can see, I don't know, yeah. As you can see, there is a very limited involvement of the capsula of the prostate, and here is a very limited involvement of the presacral fascia. And the advice was to do excentrative surgery, taking out the prostate and the bladder, and here to do a sacral resection. And certainly you will end up having a complete resection, R0 resection, and probably this will give these patients very good survival. But then again, it's in our vision on treating these kind of patients, I think we should always realize that these patients are not only threatened by the local recurrence and the debilitating consequences of having a local recurrence, but these patients will very likely develop metastatic disease. So in the end, if we treat these patients, we should have focus on their quality of life. And I think de-escalating surgery, that was our really prime goal in these patients, to have some better survival, but also to have a better quality of survival, because these patients will have a very terrible progression of disease. But you know, you must not make the surgery as terrible as the disease when it would progress, and you have to bear in mind that most of these patients still will develop metastasis. We can prolong the life with metastasis, but I would like to prolong the life with as good as quality as there is. So in these cases we would certainly do IORT on this in this field, and certainly we would irradiate the prostate if it's like this. But back to evidence and back how you can make progress in this side of field, and that's not only about from a scientific point of view, but it's also from a point of view how we can get reimbursement for this kind of treatment. And it's very important that the international structures which are there, so this is like like an ASTRO who develops guidelines for tumors, and if an ASTRO guideline is there, you can go to your insurance companies or your scientific community and say, okay, you see there is an ASTRO guideline. And at this moment there is a task force working at ASTRO to develop a guideline for intra-operative radiotherapy in many fields. Especially I'm involved in the field of locally recurrent and locally advanced rectal cancer, but there's also a guideline coming for breast cancer, for head and neck cancer, and so on. So this is very important to make any progress. But still, literature is very scarce. So if we look at the available evidence, we don't have any evidence. These are series of institutes using IORT in this kind of field, and some of these papers are about the same patient, just increasing numbers, you know. So the evidence is very scarce. And I think one of the most important things to get things going on is to have registries together. So we should work in an international way and do our registries in the same way. So I know what kind of patients you are treating based on, let's say, on a good standardized MRI scan, on a good registry of the history of the primary tumor, of the treatment of the primary tumor. We know that many variables have an impact on the treatment of, let's say, locally recurrent rectal cancer. In advanced rectal cancer, it's a little bit easier, but still there are still many variables which should be taken into consideration. If I say, okay, I treat locally advanced rectal cancer and my R0 resection rate is 80%, some of you will laugh at me and say, okay, well, yeah, I have 92%. Why should I send one patient to you? But are our patients comparable? And that problem is even more in locally recurrent cases. In locally recurrent cases, we don't have a way to compare our patients and to compare our results. So if somebody says, okay, I can do excentrative surgery without any neoadjuvant treatment, and I have very good results, and I have better results than you doing extended neoadjuvant treatment, does this prove that you don't need neoadjuvant treatment? My answer to this is no, it does not prove. It just tells you something about the selection of patients. Maybe it tells you something about the quality of surgery, but we know that, let's say, if you're talking about local recurrences after a wait-and-see protocol, these are no local recurrences. They are not. So, you know, that's the problem. We need to have a database on these patients. They are so scarce, so we should put our knowledge together into one registry so we can learn from it. And if we do that with different centers, and it's not, actually, I think we started now this thing in the Netherlands that we will have a registry of all patients that are involved in locally recurrent rectal cancer surgery. And we also ask those centers who do very few cases, but please put your cases into our registry so we will learn about it, and so we can give feedback and say, okay, yeah, you are doing well, you should become a center, or you are not doing well, please stop doing this now and then. But that's just a reflection. There's also from the publication that will be, of the task force that will publish their results, and you can see that there is a huge difference in outcome. And that is all about selection bias, I think. So we really have no idea what we're actually doing. So this slide you already did see. These are the advantages of using IORT, an extra dose, and it has some biological advantage. But in the framework of treating these patients, I think IORT is important, but it's a small part of our treatment. If we have, it's like, you know, it's the whole setup. When I treat a locally recurrent rectal cancer patient, it takes us almost 6 months before we go to surgery. And some of you will say, well, you're a madman, the patient dies in these 6 months. They don't, because in these 6 months, we will be very active with these patients. I will show you that in a few slides. So this is our this was our previous setup. It's we started with in a bunker in the radiotherapy department, but that was not very handsome to do. We had two anesthesiological teams. We had 2 surgical teams, and they liked it because they were off their base. But it was quite difficult, and so we moved on to a dedicated operating theater with one of our old Linacs, and that was rather ideal situation, but it's not allowed anymore to use a Linac for intra-operative radiotherapy in the Netherlands. So fortunately we had some experience already with the mobile system of the Mobitron system. This is our old system. In 2005 we used it already, and it did what it had to do, and now we're very happy to have a mobile system placed in a dedicated operating theater. Well, I think this is one of the messages. You need a dedicated team to discuss these patients. We have video MDTs with referring hospitals, and most of the patients so some hospitals, they want to discuss almost every patient with rectal cancer. That's no problem at all, because we give them advice and they will be treated in their own hospital. But we will pick up really some very nasty cases too. A dedicated team, a dedicated radiologist, dedicated pathologist, and so on, move on. This is our, so to skip the history we had, we learned things the hard way. So this is what we're doing at this moment now. When a diagnosis is made for, let's say, a locally recurrent rectal cancer or very nasty primary rectal cancer, we discuss really the possibility to give systemic treatment up front. This is for 2 reasons, really. I think, as I told you, many of patients with locally recurrent and locally advanced disease have another threat, which is the development of metastasis, and most of these patients will also present with limited metastatic disease. So it's not only the local problem you have to treat, but there is something else to treat in these patients. So that is one of the reasons we started induction chemotherapy in our recurrent cases when we had very hard cases. So not every case. I think you showed some of very hard cases in your slides. But sometimes, even if it's high up, I have to take out the sciatic nerve. So I have to damage the patients quite a lot. And there is a history of, already a metastasis removed during the primary. And so on, you have a bad feeling about the patient. And then we would like to have this patient on a longer observation period, respond they to induction chemotherapy. So if they respond, well, we started either a good palliative treatment, or maybe it's the step towards a more intensive treatment. What we learned from this, we started in very poor patients, and we learned that most of these poor patients in the end were operated upon, because most of these patients do respond actually very well to induction chemotherapy. Quite contrary what's always said, these are hypoxic conditions. And if you look at the MRI doesn't change very much. It's a lot of fibrosis, and the fibrosis will remain there. But when we looked at PET scans, we did see that many of these patients, up to 70%, will respond to some form of chemotherapy. So there are quite a lot of opponents to chemotherapy in recurrent cases. It won't reach the hypoxic areas, and so on and so on. Well, it's not true. It's just not true. We have now quite a lot of experience in these patients. We did treat more than 150 patients now, and most of them have responded to this treatment. Our staging is always an MRI scan, of course. It goes without saying, you cannot do anything without the MRI. And we use the PET scan. And not the PET scan to find extra disease, metastasis. It's a nice bonus if you find them, but it's especially to look at response to treatment. Then our standard, even in pre-irradiated patients, is to re-irradiate them or to give them full course if they didn't have had already radiotherapy. The waiting time, which is obligatory after this kind of neoadjuvant treatment we use for the treatment of liver mets. Sometimes patients respond so well that we give them consolidation therapy. We go on with the chemotherapy. A few cases of very young patients, we changed the scheme when they did not respond. Then again, restage them and then plan the final treatment for the problem. So my point in this is the long time of treatment. Some would say it's a disadvantage. I would say it's an advantage. It's almost 6 months. And if the patient does not progress in these 6 months, it's worthwhile to pursue and to try to treat the patients. What we do see is that in 15% of the cases they do progress and don't go to surgery. So that's you could say it's a disadvantage, but I would say it's an advantage. At least if you go to surgery with these patients, they should have a progression-free or a chance of at least having a few years of good quality of life. For full and we use exactly the same scheme in the primary locally advanced cases. So I think this is in concordance with what you've seen with Alex. One point about this idea of lateral nodes. The etiology is probably extra-mesorectal lateral nodes which have been left behind during primary surgery or been overlooked or whatever. So I think that 50% of the cases of local recurrent cancer we treat have something in the etiology of being started as either as an tumor deposit which was overseen during the primary case or a node which did not respond to radiochemotherapy. And we have been working on that quite intensively, and there is some proof for that too. And I think there will be a study very soon which will look in a prospective way at lateral lymph nodes which do not respond enough to upfront treatment. However, if this node develops to a lateral sidewall local recurrence, it's nothing looking as a node anymore. It has really changed. It is really a nasty tumor. If you have a node, you have to need to do a nodal resection, let's say in a primary cases, you just take out the nodes, it's very easy. But lateral sidewall recurrences are quite difficult to treat. These are not nodes anymore. These involve the vessels, these involve structures, and so these behave like any nasty recurrent tumor in the pelvis, and it looks nothing more like a node. So this is not something you say, okay, it's a remaining node, I'll take it out. You will be disappointed to do so. And again, this is after neoadjuvant treatment, and still you can do a very wide resection, but it would be very. I think it would be a very difficult case, and so this is a case where we would accept a narrow margin and treat the margin with IORT. So these are the kind of patients I think which are important. But since we did start including induction chemotherapy in our neoadjuvant treatment scheme, what we did see is that still R0 resections and responders are doing actually better. So this was a game changer. It put up our survival rates, and we did see even in this scheme that something up to 20% of the patients, nearly 20% of the patients, developed a complete response after this treatment. And these are the patients who are really rewarded because they have survival figures which are unprecedented in locally recurrent rectal cancer. So these are the patients who develop a complete response. And I challenge you to show me a series who have a response, who have a survival of more than 80% in 5 years.
Sorry, just to clarify, when you say complete response there, can you just explain that exactly what you mean by that?
Yeah, no tumor anymore in the specimen.
So you've gone in with the intention of actually...
We treated them, we operated on them, and we had a patient with a complete response. It's still very difficult to say based on the MRI and based on the PET scan that it will be a complete response because there will always be a remnant of fibrosis, and we don't have even our trained radiologists and cannot say, well, you know, there can be microscopic disease in this fibrosis.
So are these in recurrent rectal tumours or
yeah, in recurrent rectal tumours. Yeah, it's up to 20% in recurrent rectal tumours, and it's up to 30% in primary advanced tumours, and then I mean the nasty ones. The nasty ones, EMVI plus, T4B, and so on. So this, and in this group, we are more likely to start a waiting scheme, to start a wait-and-see program. No. No, in these T4, yeah, in normal rectal cancer, you will be seeing a complete response of 30% in T2 disease, but not in T4B. No, you won't. Certainly not. 30% complete response in T4B, I never did see it. We looked at our nationwide data, and you can achieve in T1, T2, you can achieve something like up to 30%, and then it goes down. T3, it will be 20%, T4B, it will be something like 10 to 15%. So, and now we see that induction chemotherapy, and that's in line, you know, there are study and publication from Sloan Kettering and Yarmouth Surgery last year about they call it total neoadjuvant treatment, but they were not the patients we would consider probably for IORT, but the patients that have a nasty advanced tumors, and they did see a doubling of the complete response rate and persisting complete response rate. So, well, another thing we learned when we started this this treatment, we said if there are recurrences, if there are metastases, you probably should not do this, but we changed that for some 15 years ago. And even now, peritoneal metastases are not an exclusion criterion to consider these patients for treatment. And in fact, if we look at the recurrent cases, I think there is a good argument to treat both the recurrence and the metastasis. This is one of our, when we started using induction chemotherapy, it started in the patients that had already previous radiotherapy for the primary, and that was the first time we did see that you could achieve a complete response, because in our regular series it was something like 7%, 6 to 7% complete response after chemoradiotherapy, but we could see that we could achieve, even in those re-irradiated patients, very good responses.
Going back to the complete, so do you think that increased response is because of the chemotherapy you give after the chemoradiation?
Yeah, that's the only thing we changed. So we did chemotherapy before the chemorats. We did it, we gave it as induction chemotherapy.
And in that waiting time of 8 to 10 weeks, you're giving a further chemotherapy?
Yeah, in our first patient we would give 3 cycles, but now we're at the point of changing our protocol. Instead of giving consolidation therapy, we will go to all the chemotherapy before the chemorats, and then but do the evaluation a little bit earlier with a PET scan. If you have a not responder, there's no sense in continuing this. So we will give all the systemic treatment before, then do the chemoradiotherapy, and then there is an argument not to wait too long after the external beam radiotherapy. I think the radiobiologists amongst us will say this repopulation is a thing that's going on, and if you wait too long, you will have problems with repopulation. What we also did see is that since we changed our protocol, our R0 resection rate went up. It went up something like almost 20%. So we are down now to something like 80% R0 resections, between 70 and 80%, and it seems to be steady. So there seems to be a reason for that.
What sort of timescale do you have between the end of radiotherapy and surgery?
Well, it was quite long. It is about 12 weeks, 12 to 16 weeks even. And that's that is a thing we have to change, because it's not because it is bad, because these patients recover very well and they will. We don't see any big problems after doing the surgery after 12 weeks or so. It doesn't increase the number of complications. But I think the effect of, and I will show that in a few slides, the effect of the IORT is less, or maybe we should increase the dose.
Sorry, I beg your pardon. Are you able to predict the complete responders on your MRI preoperatively? And are you tempted to adopt a watch and wait policy as the rest of the sort of rectal cancer?
Yeah, it's there. You know, we don't have microscopic eyes. Even the best radiologists cannot tell if there is still some microscopic residual disease in the fibrosis. They can tell you, well, this is more than 90% fibrosis. They can tell you. They never will tell you it's 100% fibrosis. They will tell you, I think it's a complete response, but they don't swear on it. So that's the problem. But then again, so if you have such a patient, you think he has a complete or she has a complete response, there's no problem in waiting a little bit longer, looking at CEA levels, looking at maybe circulating DNA, maybe looking at PET scanning them, and especially as if these patients are old, our senior citizens, I think there will be a point in that some patients do not have to go to surgery, even in locally recurrent disease. Well, this is quite obviously, we looked at our data and we did see in our primary cases that when we did see response, it's quite obvious that you will have more R0 resection. But this is quite interesting. We did a study with the Mayo Clinic. When we started our program, we were instructed by the Mayo. They visited us and we used their protocols, and so we think it was our data are a little bit comparable. And what we do see, and this is very interesting, if you look at the patients that have been operated in this kind of period, it seems that the use of IORT in these patients, in R1, in R+ resected patients, seems to control the local recurrence, as if you have an R0 resection. So this is a plea for not waiting too long. Did I make myself clear? Because there is a counter effect. If you wait long, you will have more response. So after 12 weeks, you have more response than after 5 to 6 weeks. But the effect, and so achieving an R0 resection, so if we looked at the patients where they waited longer, where we waited longer, then we saw that you get more R0 resection, but if you have not an R0 resection, you have a more likely chance to develop a recurrence. If you're doing the surgery a little bit earlier, then you can control R1 resections.
You don't know whether the percentage of those would have become an R0 if waiting longer.
No.
So,
you don't know. You don't know what happens to these patients after. Yeah.
In more than 12 weeks, you got
Yeah, it could be It could be the selection of, yeah, it could be the selection of patients, yeah, that's true. It could be the selection of patients that would have an R0 resection. So these patients, but still, the number of recurrences in these patients that were operated in this period is smaller than if you wait longer. And of course, this is a selection of patients because it's also because they have problems or whatever. But yeah, well, this is explained in figures, and you did see that if you compare these patients, they have, in the end, they have less local recurrences. But again, it could be a selection of patients. We did see, actually, we did see the same also, the same in advanced cases. So if you don't wait too long, an R1 and an R0 resection have similar local recurrence rate. So this is maybe a plea not to wait too long. But again, it could be a selection of patients. Again, not waiting too long. This is the alternative. Alex mentioned it already. It's the alternative to use a high-dose rate brachytherapy machine. There are some advantages. The best would be to have both worlds in your operating theater to be able to change from one to another, but what we do see is using high-dose rate brachytherapy is that these are data from a study which was done from a high-dose rate brachytherapy center in Rotterdam, and it shows that R1 resections have quite the same overall survival than R0 resections, but they used it in very selective patients. A short word about re-irradiation. I think still re-irradiation is not accepted as a standard in many countries, but we do see that if the outcome of patients that have a re-irradiation scheme or a full course scheme are almost the same. This is again from the Mayo and Catharina Hospital pooled analysis. This is from our own hospital. We did see again that the survival rates of re-irradiated patients were almost the same as the patients who had a full course. Then, so let's go back to what evidence do we have. This is a slide I think all of you will have.
In terms of people who you've irradiated twice, surgery must be more technically difficult.
Well, yeah, it is, but then again, doing local recurrence surgery is demanding, and I don't think that the addition of a little bit more fibrosis is a big game changer. I don't think that. So this is something we learned from our regular rectal cancer treatment. So the margin is important, and the distance is important, and well, it was in the English study, it was in the Dutch study. However, this is the only thing I really think is if you look at margins in locally recurrent rectal cancer, you see that if we have a positive margin, the local recurrence rate will go up, but if we have a close margin, it's acceptable. So this is the game changer, I think, in our planning of surgery. And if you remember the slides I showed you in the beginning of the Royal Marsden paper, so IORT allows us to accept close margins. We still have to do our utmost best to achieve an R0 resection, but a close margin is acceptable.
So just if you say that the close margin is acceptable and you believe the same as an R0, are you trying to sort of imply that in some cases a bad surgery can be compensated by giving a bit of a...
No, but if you do your utmost best to, let's say, to preserve the sacrum or to preserve the prostate and not doing a cystectomy, then it's acceptable, and you can avoid sometimes.
Balance of intention to treat versus sort of morbidity, isn't it?
Sorry, so you mean?
What I'm saying is I agree with you that it can be used very judiciously in patients where the
Mhm.
But to accept as you described, to accept a close margin or a positive bed, for example, at the expense of doing more radicality that would increase morbidity.
Yeah, that's a balance we have to make. Yeah. And sometimes this is really, and sometimes it helps you, not in the very nasty cases, you cannot do, if the prostate is invaded, then probably you cannot compensate it by IORT. But if there's just an adjacent thing, then it is possible. So that's what I wanted to tell you. Still, these major surgery taking many hours is really necessary. I will skip this. It's a study from the Karolinska who looked at these lateral sidewall recurrences, and it was again referring to the question a little bit earlier. These sidewall recurrences are still quite a challenge. And then a few words about an upcoming study. In the Netherlands, we will have a study on induction chemotherapy in locally recurrent rectal cancer, but there is an initiative to try to widen this study because the number of patients which are needed for good evidence is quite high. So there will be a discussion about induction chemotherapy in Dublin over in 2-3 weeks. There will be the pelvic group together, and this will be something like the scheme. It looks quite the same as what I did show you, but again, the induction chemotherapy is limited to the radiochemotherapy, and this is the scheme. And the IORT is not obligatory because I think we would scare off too many centers, and it's open, I think, also for centers who do not have IORT, and we will learn from them also. It's a quite straightforward setup which we will have in the Netherlands, but the thing is, we do believe that we can still do a randomized controlled study if we start very soon. Because I also believe that if we wait another 2 years, everybody will use induction chemotherapy. And just like when we started IORT, and this was the last resort for really hopeless people, so you couldn't do a randomized study because they came to you with their disease, and it was almost unethical to propose to do what we had, very, very bad results, versus what we hoped. So I think there's still room to do a randomized study, so we will try to start this study as soon as possible. And the primary endpoint is the most important prognostic variable. So to come to my conclusion, I think there is a potential role of IORT in those patients with a close margin or even an involved margin, as was pointed out. But I think we do not understand already the radiobiology as good as we could do, and I think there is room for improvement. What we also do not know, well, when this was started some 35 years ago in MGH, they made it a choice to use 10 gray. Maybe we should use 15 gray. We really don't know. And if there is a longer waiting period, maybe we should increase our dose. Really, we should. But most importantly, I think it's part of an integrated approach. It's not only about seeing once in a while such a patient and say, okay, well, I was in Southampton and Rutten told me to give induction chemotherapy and then go on. I think we need teams. We need dedicated teams, and therefore you have you require a good registry, and you require good cooperation to combine these patients. Yeah, and IORT facilities, well, they are a tool and can be an important tool to help to build these centers. Thank you.